we're on to part 2 here. There we go. So we went through the common causes of range of motion restriction, where they come from, the different things that can be impacted that cause the range of motion restriction. In the last PowerPoint, we're talking about what we can do to be able to impact those pathologies from a treatment perspective. We got a couple things in our quiver that we can use to try and address range of motion restriction pathologies. One of those things is going to be range of motion. So what is range of motion? Well, you guys know this because we've done tested measures, but range of motion is just a basic technique, the way we're going to discuss it, for the examination and initiating of movement. So know that definition for sure. And it's going to move a body segment. When we say movement, a body segment is going to move, and its range of motion will affect multiple structures. So it has to do with muscles, joint surfaces, capsules, ligaments, fascia, vessels, nerves, even skin, right? Integument, that's not listed here. So these are some of the systems that will be responsible for contributing to movement, involved in generating or involved in the process of movement, and also potential areas of restriction that can cause loss of range of motion. So all things to consider. Understand the difference between joint range of motion and muscle range of motion. So when we describe joint range of motion, we're talking more or less about the movement of one bony segment as compared to another bony segment surrounding a joint, where that articulation happens. And we measure that with a goniometer. Muscle movement or muscle range of motion is more related to functional excursion. If you go back to thinking kinese, functional excursion has to do with the distance a muscle can shorten after being maximally elongated. So the excursion of the muscle is sort of taking the maximum elongation and the maximum shortening and measuring the movement in between, if that makes sense. Okay, muscle range of motions are going to be impacted by our concepts of active and passive insufficiency. Go back to kinesiology. You guys should know this before. This is the length tension curve. Active insufficiency is at a two-joint muscle. It is the point where the muscle can no longer shorten any further. Passive insufficiency, you guys should know, is the point where the muscle cannot lengthen any further. Examples being elbow flexion and supination with shoulder flexion would add up cumulatively to all the muscle actions of the bicep brachii in aggregate. So it's as short as it can possibly be. We take it, we do all the things the muscle does, and we put it in a completely shortened position as far as it will go. Passive insufficiency is going to be the opposite. So if I extend the elbow, do the reverse, pronate the forearm, and extend the shoulder, I've placed the biceps now into passive insufficiency. I've taken all the actions that it normally does or is capable of doing, flip them around, reverse them, and now put the muscle into as much lengthening as I possibly can. It's passive insufficiency. So here's some examples. You guys know all these. All right. Go back and look at them if you can't remember. Skip through those. Good. So we have different kinds of range of motion exercise. Know the differences between each one of these and how they can be used to address certain kinds of pathologies, right? So passive range of motion is going to be a movement within the unrestricted range of motion for a segment that is produced entirely by an external force. So there's no voluntary muscle contraction with passive range of motion. Something is going to do all the work, but it won't be the patient. It will be me, the therapist. It will be a mechanical machine or something like that. It can be the patient's other body part, but something else is producing the movement. Active assistive range of motion is a type of active range of motion, but it's not full active range of motion, right? There's assistance provided by an outside force, either manually or mechanically, again, because the muscle or the prime mover needs help to be able to complete the motion. So this would be an example of, I want you to lift your arm as high as you can, and when you can't lift it any higher, I'm going to take over and help you get the rest of the way. So we ask the prime muscle mover to do what it needs to do or do what it can do, but it may be weak to some degree, so it needs assistance to complete the range of motion. Active range of motion is movement within the functional or the unrestricted range of motion for a segment that is produced exclusively by active contraction of the muscle crossing the joint, right? Nod your head up and down. Bring your ear to your shoulder, left and right. Rotate your head, right? Like you're saying no. So that would be active range of motion. Passive range of motion is indicated when the patient's own muscle force is not efficient enough to be able to produce safe or effective motion. This is why we usually start people off early with passive range of motion, because if someone's early on in the healing process or the rehab process and they're at like a max protection phase, or they're acute within the healing process, like inflammatory or bleeding phase, they may not have, or there could be contraindications to certain types of active range of motion. Just might not be able to do it. So we start passively. Active muscle contraction would be harmful, like if soft tissue, muscular tissue was trying to heal, or a tendon that had ruptured was trying to heal, or a surgical intervention has been introduced that needs to heal. Also an educational process, and you can use it for assessment techniques, right? Passive range of motion we can measure. You can educate the patient on, like, I want the movement to look like this without any compensations. I'm going to show you how to do it. This is what the movement feels like, right? Know the benefits of passive range of motion. Again, these are the big ones. So you have effects on the tissue and then clinical effects, right? So stimulates healing, enhances healing of incisions, improves synovial joint fluid motion, right? Motion is lotion. So it has those effects on the tissues, and because it affects the tissue that way, we can help to decrease pain after surgery, allow for a faster return, moving a joint passively at the forefront rather than just immobilizing it, and usually decreases the length of hospitalization. Right? So there are more effects here, right? We can improve the nutrition, know all these effects, and know their clinical benefit as well, right? So we have an effect on the tissue, and because of that effect on the tissue, we've got some clinical effects that we can play off of to improve the patient. Right? This is when you're not going to do passive range of motion. When it's going to interfere with active tissue healing, obviously, if something's trying to heal, I don't want to go ahead and move it or put force against it, right? In the presence of extreme muscle guarding in certain conditions, it can be counterproductive to actually try and passively move. Or when you have a strong increase in pain, right? Precautions may include just when it temporarily increases the patient pain. I can promise you that you'll do passive range of motion on it, and it won't be their favorite thing in the world, right? But it's not necessarily that we can't do it. Or it elicits an undesirable amount of muscle tone. So here's some common dosages. Know these. You may have to alter these depending on the presentation of your patient, right? So there's a general sort of rule of thumb for how passive range of motion is introduced. But in some cases with neurological conditions that have a tonal quality to them or a tonal abnormality, we may need, as is the case with our spasticity, we might need to slow down the reps because there's a velocity tied component to spasticity, right? Velocity dependent component, and we might need to extend our hold at the end ranges beyond where we normally would for typical passive ranging. All right, so there's passive range of motion. This is the big thing. It's not going to have a thing to do with preventing muscle atrophy. Why? Because there's no contractile agent, right? There's no contractile force being incurred, right? We're not asking the muscle to contract. So without contraction, I can't have any degree of strengthening or contractility. So it's not going to help defend against atrophy. It won't increase your strength. It's not going to increase your endurance or activity tolerance. And it won't have the amount of impact from a circulatory perspective as compared to active voluntary muscle contraction, right, that you get with a muscle pump. All right, so there's limitations repeated. Active assistive or active range of motion, on the flip side, is going to be where the patient can actively contract muscles and move that body segment with or without assisted, right? So, and no other contraindications. So there may be other things at play that we need to consider, but that's a general rule of thumb, is when you can actively contract, you're ready to at least participate in active assistive or active range of motion. Now, not always the case from a protocol standpoint, but we'll see that. Accomplish the same goals of passive range of motion, right? Because we're moving things, but now you get the added benefit of having muscle contraction on your side. So you can maintain the elasticity and contractility of the muscle by asking the muscle to contract. So you're going to get more sensory feedback from the contracting muscles. You're going to get a stimulus for bone integrity, right? Because the bone needs the muscle to move, right? So we're going to ask to put some level of resistance on the bone to increase integrity. Increases circulation, like we talked about. It helps to minimize thrombus formation that could be the result of immobilization and stagnant blood. So we're going to pump that with a circulatory intent. And develop coordination motor skills for functional activity that require contractions. when you have active or active assistive range of motion, all the passive range of motion contraindications we talked about are going to hold true in addition to some other things, right? So pain throughout the movement or that's persisting after the activity, right? You killed me. I was sore for 3 days after that. Development of dysfunctional muscle tone. So if adding active range of motion contributes to or furthers dysfunctional muscle tone, no good. There is a contractile component to this. There is a cardiovascular component to this. So we have to know that the cardiovascular system is not distressed and is capable of being able to keep up to that output, that performance. So you have to know the med history, and then other adverse side effects to exercise, inflammation, effusion, other things that may be contributing or comorbidities surrounding just exercise in general. So same precautions for this. If it's going to generate undesired movements or physiological demands increase patient risk. So knowing the health history, being aware of what pathologies are going to respond what kind of way to introduction of active motion exercise, more or less. Okay, determined by patient response. So obviously we're working somewhat actively. You got to look at fatigue, you got to look at pain, going to look at the quality or the accuracy of the movement. This has to do with sort of cheating, right? Are they compensating? Are they having a pretty good concentric component to the movement, but then when they go to eccentrically lower, they just drop it, right? There's no control, things like that. Vital signs, right? And then we're also just keeping tabs on the general systemic health and well-being of the patient through the vital signs. Really good chart table in Cameron for types of range of motion and when you might use them. So that breaks it down. I love the charts, right? Always look at the charts. If you don't read the book, at least look at the charts. Special considerations, right? If the range of motion of a body or a body segment is mobilized for a long period of time, it doesn't mean that just because that part is immobilized that you can't work on other things, right? Feel free to work above and below the immobilized segment. The body works in unison. It's an orchestrated concert of events kinesthetically. So if just because the knee can't work doesn't mean I won't need to and can't work the ankle and the hip. Maintain areas of normal conditions as possible, right? So maintain those areas and then also prep for functional activities. So you can have them doing functional activities, even immobilization, right? As long as they have a weight-bearing tolerance that, from their protocol perspective, that allows you to do this, you can fit them with the appropriate assistive device and start them with the process of ambulating, doing transfers with the use of assistive device. Also, don't sleep on cardiovascular endurance training, right? You may not, just because I can't use my knee doesn't mean I can't get that patient on a upper body ergometer and have them crank away at that to try and increase their endurance, their cardiovascular endurance. So here's range of motion. Posture, body mechanics are key, as always. Body mechanics include keeping the table height appropriate or the bed height appropriate. That's to protect you. Prep the treatment area appropriately. That's for basically the patient, sanctity of the patient's positioning, draping, safety, experience, etc. And then the frequency and number of reps you can manipulate. Right? So those are general principles. As a rule, usually you're going to stabilize the proximal joint using a lumbrical grip, which is going to have to do with, not like death gripping them, but using sort of a soft grip initiated from the metacarpal phalangeal joints, more or less. Moving through the range of motion slowly with a brief hold at end range and light overpressure, slowly being the operative word, right? We're not just ranging them high speed. Range of motion end feels, you guys know these by now. Abnormal versus empty, know the difference, right? Know what your normal physiological and your abnormal end feels. Functional patterns, right? So we're teaching ADLs and sort of ADLs that are appropriate for like interdisciplinary functions like going to work, going to school, except like things like that. All right, so you choose your plane of motion when you're doing range of motion. We learn all the planes in straight planes, right? Transverse plane, sagittal plane. This isolates the motion, makes it easier to measure. That's why it's more appropriate for examination and treatment. And you can kind of combine motions in two or more planes to do things like stretch and range. So a lot of our ranging happens in straight planes because it's an easy starting point and it's easy to measure and it's easy to implement, and it sort of simplifies the treatment. But after a while, we got to use a systemic approach, right? Or a systematic approach. So you're going to do all the movements in one position. It makes it easier for us, but this is just an example of saying, like, I'm going to do all the things I can do in supine first before I bother this patient to move into side lying or into prone, etc. Right? So it's all going to depend on the patient. So use your systematic approach. What I was getting to before is straight planes of movement are great, but they're not super functional, right? So most of our movements tend to happen in diagonals or combinative planes. So diagonals are closer to daily functional movements. We see these through PNF patterning, like we talked about in lab and in lecture. So they don't allow for isolation. So they're not really appropriate for examination, right? It makes it really hard. I can't measure like, okay, they had this many degrees of D2 extension and flexion. It's just not succinct enough, right? There's too many things going on. But the truth is that combined patterns of motion are much more functional. So I'm going to measure and assess my patient in straight planes, but I'm typically going to try and at some point when it's tolerable to the patient, train them in diagonal or PNF type patterns that look a lot more functional, right? So movement patterns described in proprioceptive neuromuscular facilitation. That's PNF. There are patterns that incorporate diagonal patternings of motion that have rotational components that are there to allow and restore functional movements because they look more functional and they involve multiple joint movements happening in unison. And we have these for the upper extremity and lower extremity. Got good videos. That is a horrible, horrible picture. You can't see anything. Linked some really good videos in your module. Look at those for sure. Self range of motion makes sense, right? Patients can use other extremities to perform passive range of motion, or they can use things like towels and pulleys and canes to do passive or active assistive range of motion. That's going to constitute like a lot of your HEP work. Continuous passive range of motion is a mechanized form, a mechanical device. You can see it here. It's a big old machine that's going to perform passive motion at a joint slowly and continuously through a preset or controlled range of motion. So the cool thing is it keeps the body moving or the joint moving and can help defend against adhesions and contractures, stimulates healing of tendons. So all the good things basically of passive range of motion, like we're looking at pretty much all the stuff that we talked about in terms of benefit of passive range of motion. The nice thing is that you don't have to have someone physically doing there. You can monitor exactly how much range of motion or how little range of motion you want. And you can set times, right? You can do it for a certain amount of time, like put them on this for 4 hours. So you put it on right after surgery. The arc of motion is adjustable. The rate of motion, speed is adjustable. How long the machine is on is determinable and adjustable. You can do your PT during the off periods. They can have it just in the bed. When you bring it back to the room, they're back on the CPM. There's a video. I posted the link there as well, so that's a good one to look at. This is how we document range of motion. So the quantity of the movement, right? This could have to do with, how far, goniometric measurements, right, of that movement, how many times we did, how many reps, right, how many sets, quality of the movement, were there compensation patterns? Did I, feel anything from a, intra-articular, extra-articular quality standpoint that made me like, oh, that was clunky or that was weird or there was a popping sound. That's down at the bottom. Patterns of movement, right? What patterning of movement did you see? Did you see any compensation patterns? Did you do D2? Did you do, what movements did you do, honestly? End feels, right? Was it hard? Was it firm? Was it abnormal? Was there pain? How much pain was there? Was there notable muscle tone, spasming or guarding? And did it click? Did it pop? Any sounds associated with it? So that's going to take us pretty much through range of motion. I'm going into a little bit more depth here than just looking back for the quiz because I really want, this is a fundamental tenet of what you guys are going to need to do. So it's important that you really internalize this, not just from a more or less like a school study academic lens, but find as many people as you can, get your hands on them and start to work through functional patternings, work through your range of motion, try out your active, assistive, passive range of motion, grab a son, a daughter, an uncle, a cousin, whoever you got, to just get as many reps as you possibly can on that. So that'll wrap up for this video. And what we'll do is move along. The next one we're going to discuss is our PowerPoint on stretching. So I'll see you guys in the next PowerPoint.